Just to summarize briefly, we've had a presentation on the state of COPD and several models of how to manage patients with this chronic disease and focusing on education, communication, and innovative strategies. And I think that we have a set panel of questions that we can discuss. We can start off with this one, our first one, because we've been engaged with specialists, and specialists are often the lead people involved with the management. But the question comes up, the primary care for COPD patients, how can that be integrated in these healthcare models that actually don't require a primary care provider for utilization? And that includes our more traditional PPOs, provider organizations, and fee-for-service. Just let's start.
I can jump in if you'd like. I'm the poster child for this. 9-year asthma patient. I never talk to my PCP about my asthma. I go to my specialist. I'm on a high deductible health plan. It has been a challenge for me to work personally with my specialist in a high deductible environment where I'm paying the cost for my prescriptions and my costs. And it's been a little bit of a challenge to educate my physician to give me information so I can treat my asthma properly. In my 9 years, I've never been a good patient to connect with my PCP on this, but at the same time, my specialist hasn't either, so it's a fault for both of us. But I know as the Affordable Care Act rolls out, I work with employers and individuals. There is a propensity to move people to higher deductible health plans, higher co-pays, higher deductibles, and this is going to be a continued challenge. I'm very optimistic about this. I'm a much better patient now than I was 9 years ago. When it became my pocketbook, I started paying a lot more attention, asking better questions, and I actually went from that person who, when this $168 prescription for my asthma medication, I wouldn't fill it. 2 weeks later, I got 3 other prescriptions from my specialist to get a more affordable asthma medication. A few years later, I actually decided to buy a more expensive prescription because it worked better, but that was a very informed decision that I made personally. But I think these are the points we need to connect together, because these are issues that are going to be first and foremost for everyone as they gain health insurance, sometimes for the first time, or changes in their health plan.
I'm not sure if it's PCP or specialist that needs to be, but I think has happened really is that the Affordable Care Act, or Obamacare as it's affectionately known, is it's rather like Humpty Dumpty. It destroyed, now the whole system is shattered into 1,000 pieces, and everybody's trying to put it together again, and that in fact is the plus. So we have an opportunity right now to in fact put it together again, and I think we have a lot of very good individuals working to put it together again in a way that comes together in a more improved format. So essentially, what I think the key principles here are value, not volume, payment reform so that incentives are aligned across the spectrum of the providers, and so that the physician is not bound to a system where the only way they get revenue is when a patient crosses the threshold of their examining room or office and the cash register goes to check. So the idea here is within our Anthem network, we have now 11 medical groups in California which are part of our company care organization structure, stretching from rather like the Camino Real from San Diego to the north, with a mission every couple of every miles. We have the 11 medical groups stretching from San Diego to Eureka, covering now close to 300,000 Anthem PPO members. So the infrastructure of the HMO medical groups, which has been well developed in California for the past 2 decades, is now being turned 180 degrees to face the PPO world. Not without some resistance, but all of a sudden the PPO world, which previously had its value because it was unmanaged and patients and physicians had a great deal of freedom, are now being approached to develop management and structured and team approach to care so as to improve the overall management of chronic diseases amongst which of course is COPD. So I'll stop there and expand on that later.
Yes, I'm a little bit further down the spectrum. I'm the chief medical officer of CareMore Health.
We like the company so much we bought it.
Yeah, you we're a Medicare Advantage company. We have 77,000 members in 5 states. And we adopted a chronic disease management plan about 20 years ago when we developed a big infrastructure to support it. And we have what's called special needs plans for COPD, CHF, end-stage renal disease patients on hemodialysis. And we have developed a value proposition in PCPs. And the value proposition is, we will take care of your chronically ill patients in our chronic disease management programs, and we will bonus you for not seeing these patients. We have found that, unfortunately, many PCPs have a difficult time managing COPD, CHF, end-stage renal disease. And because we are a Medicare Advantage company, we're responsible for all the admissions, all the DMEs, all the pharmaceuticals, so that we have sort of, in a way, bypassed the PCPs for chronic disease management. And it's mainly run by pulmonologists and nurse practitioners who work for a pulmonologist, who see the patients on a regular basis. We actually provide free transportation, so we see the patients on a regular basis. And the patients who don't want to be enrolled in our chronic disease management company program, we actually have case managers who outreach to them on a regular basis. Each year we have what's called our Augmented Pulmonary Initiative, where we send a letter to all the patients who have COPD that you have COPD. This is what you can expect. These are the medications you should be on. If you're not on these medications, you should talk to your PCP. If he doesn't have you on these medications, we will provide them for you. And we have also, because of the cost problem with COPD nebulizers, we have formed an agreement with a compounding company to actually make generic medications that they can use in a nebulizer if they can't afford the metered dose inhalers. So we are always looking for new ways of dealing with patients with COPD so that they don't get readmitted. And if the patients do have on oxygen and have decreased FEV1s, we provide our own pulmonary rehab. We don't contract with pulmonary rehab providers. We actually developed our own gymnasium. It's called Nifty After 50, where we provide free transportation where they get pulmonary rehab under our direction. So we've sort of internalized everything that can go wrong with the COPD patient, that we manage them 100% of the time.
This question really tries to address the issue of whether this chronic disease management is better specialist-driven or primary care, partly because obviously there's more primary care providers and specialists, and patients who may have undiagnosed COPD are more likely to encounter their primary care physician initially.
We encourage spirometry yearly because it's one of our HEDIS criteria. And if the spirometry, they have COPD, we actually try to encourage them to be seen in our chronic disease management program. And we also try to educate the PCP on what medications they should be on. We send them a letter, this is what they should take. And if they have exacerbations, this is how many steroids you should give them, this is how many antibiotics you should give them. And so it works both ways, but in our chronic disease management, we find that nurse practitioners working with a pulmonologist seem to have better outcomes than PCPs. Unfortunately, that seems to be the case.
Yeah, I think that as far as chronic disease management goes, and this model we're talking about is really directed to the high-cost chronically ill. And in our populations, which we see, we find that 1% is responsible for a quarter, 5% is responsible for a half, and 10% is responsible for 2/3 of the total healthcare costs, amongst which are all those chronic diseases, which around COPD is clearly important. So the management, I'm not sure that it's a universal model where it would be PCP or specialist leading, but it's really recognizing that it is it's not just one individual that's going to be able to manage it. Certainly a 10 or 15 minute office with a specialist is still not going to do it. So I think within our world, it's looking to see that everybody in the team functions to the maximum of their capability. So if it's the receptionist that is calling the patient to come in for the spirometry or reminding them that these instructions are being enabled, that's part of the role of this team approach. So it doesn't just have to be on the trained or the licensed individuals. And I should also mention that as part of the reimbursement restructuring within this new accountable care work, there is, in addition to the fee-for-service, which the idea behind the Affordable Care Act is low fee-for-service away in time, but we provide additional payment through what we call care management fee. So it is based on capitation, but it's a supplement to the fee-for-service. And then at the end of the year, as far as the entire group is concerned, there is a gain share arrangement, which is based on the bending the cost curve down overall between what the trend would be and what it is, and that is shared with the provider community. So it's a three-part reimbursement together with a team approach.
It's open enrollment season for employers and employees, and one of the challenges and opportunities I see is it's pretty consistently noted that when we ask people if you've even had a physical in the last 2 years, only about 20% of the people raise their hand. So if we can't get people in to see the primary care physician just for an annual physical, which is now free, no cost sharing, then we can't even address some of these issues. So definitely getting more access and education to the individual and reminding them this is a positive thing, then we can't prevent some of these things, which is...
Not about just jump in there a second, because none of the primary care societies actually advocate. And in fact, it could increase costs because you find things that are irrelevant to our industry. So I understand that there is the word out there that annual physicals are good, but neither the Canadian nor the American College of Physicians nor the American Academy of Family Practice advocate annual physicals. What is necessary is there are a set of defined things that need to be looked at in terms of cholesterol, blood pressure, etc., which can be done without doing a whole rigmarole of unnecessary EKGs and stuff, which is in fact part of the true pricing advantage. Another issue we may not have time to get to. And also with spirometry, and I am a lapsed pulmonologist, so I am a little unfamiliar with the most recent data, so I have to stand corrected if I'm wrong. But there is no advocacy for universal spirometry screening in a healthy population. It is, I think, directed, so
That's correct.
So we need just to be careful about opening the floodgates and saying everybody come in, because it actually can, I think, just raise costs because unnecessary things are found.
Well, maybe I can proceed with that next question here, and it deals with how healthcare plans ensure best practices in chronic disease without compromising costs. I think it's a natural segue into that. And I think the best practices, as recommended by national organizations, the GOLD criteria includes spirometry and other practices, symptom-based management, pulmonary rehab, etc.
We always think of non-compliance as our problem, not the patient's problem. And we have a team of pharmacists who actually monitor whether the patient actually picks up their medications on a month-to-month basis, because that's also one of the newest guidelines that with Obamacare, we get penalized if we don't do medication management and making sure the patient actually gets what he's been prescribed. And in terms of oxygen therapy, we're actually pretty liberal with oxygen, and we don't always go according to the pulse oximetry. We sort of leave it up to our hospitalists and intensivists, saying, if you think oxygen is going to keep them out of the hospital, maybe we ought to give them oxygen. And we also make sure that everybody gets their flu shots and pneumovaxes on a regular basis, and because we're on EMR, we can all see if they actually got it. So following best practices has actually dramatically reduced admissions and readmissions in the chronic disease management model. But once again, unfortunately, PCPs alone, it's hard for them to do all these things because they don't have EMR, they don't have the time, they don't know how to teach the patient how to use nebulizers. That's why we sort of have internalized all that and have a much better outcome.
No, I think that's an interesting issue. The cost issue comes up, and there have been a number of recent experiments on bundled payment, for example, getting a lower price for common rehab rather than a per diem or a per procedure. And that's important from the value proposition in terms of outcomes. So if you have a institution, a group, a hospital, a clinic that can document their outcomes in terms of a common rehab program, and then say this is what it costs, it's easier then to deal with how one should direct the patient rather than just say, well, we have a team of specialists that graduated from Harvard, Yale, and Johns Hopkins, and then charge what they wish. We particularly have instituted programs now, one in California, not for COPD, but I think it will come for chronic disease, but recently for hip and knee replacement, where with a large employer in California with CalPERS, we fixed the maximum price at $30,000. And any hospital that charged more, the patient could go, but they paid the difference between that and what the hospital charged. If they went to the hospital at 30 and below, they got it covered completely. So this kind of reference-based pricing and these innovations are things that can change the perspective in terms of how we fund this appropriately, but we look for outcomes and value at the same time.
And the question comes of how do you ensure that oxygen is not used beyond its necessary indication?
That's why we see the patients frequently to see if they still need the oxygen. Frequently after an exacerbation, we'll be very liberal with the oxygen. And then when we notice that they just have all these extra tanks at their homes, because we have home physicians who visit them at home, that they don't need it anymore, we start pulling back. So we do it much more clinically based than just pulse oximetry based, because we found that if we just went strictly by pulse oximetry, we just had too many recurrent admissions. So we let our clinicians decide when they need oxygen rather than strictly going by the pulse oximetry.
But still meeting guidelines for oxygen, low oxygen.
Yeah, but
Yes.
we're, like I said, we err on the side of being
Yes,
liberal
yes.
with oxygen.
I just wanted to clarify that, since none of us would give oxygen to somebody who doesn't really need it.
No, but it's sort of the patient's
Favorable.
Yes, unless you're going to Hollywood.
I could just jump in and say, as an advocate for individuals, I really hope we can all keep a thought on the patient experience. My dad called me on Monday, and before we could even say hello, he said, I need to find a new doctor in a new facility. The surgery I had scheduled, they're not answering my questions, they're not giving me information, I'm not going to go there for my surgery. I'm now going to start the process all over somewhere else, and that's a waste of resources for all of us, and he is walking away frustrated. So one of the ways we can control cost is, have a good patient experience and make sure they're taken care of on the front end, during, and after.
Yeah, that's a great point. And in fact, as part of certainly it was in the HMO world, but now in the PPO world and in Medicare, fee-for-service was a pioneer ACOs. Patient experience and quality metrics are a critical component, and in fact, the shared savings are not. They're not distributed in the event of quality thresholds.
Coordinated, continuous care as being part of the new paradigm. Maybe I can just go on to the next question here. And I guess part of that includes best practices. I know any of you want to discuss things as smoking cessation. We've already touched on oxygen and pulmonary rehab, because these are issues that often come up with the patient with COPD or any chronic disease.
Sure. I can tell you again, working with employers, that they are very into wellness programs, population health management programs. They are very thirsty to put in programs to improve their employee health, so that will improve their productivity. One of the challenges we have with the Affordable Care Act, or at least California, is they limited the smoking cessation incentive that employers were allowed to have. So, however, employers do get really good data on what percentage of their population are smokers. For example, they'll never, of course, for privacy reasons, know who it is, but they'll know the percentage of their population, and that is a tremendous opportunity to then reach out to those populations and get them engaged in their health care.
Yeah, I think the benefit structures that Anthem promotes certainly builds on these wellness programs, and that's part of the packages we sell to large employers. As an employee of Anthem, we get a significant reduction in premium if we know our numbers. So if we have an annual cholesterol, blood pressure, or check and attest that we are no longer smokers, there's a several $100 break on the premium. So these are kind of programs that we promote.
We also promote smoking cessation. We do zero copay for Chantix, and we have education classes for smoking cessation. I'll be honest, the success rate is not that impressive, but we keep trying. In terms of pulmonary rehab, we found that to be very effective. We internalized it because it was quite expensive to do pulmonary rehab on an outpatient basis within the hospital. So we developed this actually gymnasiums that we own that do pulmonary rehab with kinesiologists and physician on standby. Quite effective in reducing medication requirements. So once you're sort of responsible for every aspect of the patient's well-being, you sort of dream up different ways of tackling the problem.
Let's add one thing on cost, and I want to just put a plug in for choosing wisely. Nothing to do with me, but I think it's worth emphasizing. For those of you who haven't heard of choosing wisely, it is a program for the American Board of Internal Medicine, or the Foundation. And ultimately, started a few years ago, we have now 50 specialty societies in the United States that have each developed 5 doses that physicians should not be doing. So cardiologists don't do EKGs in asymptomatic middle-aged men, and you don't do DEXA scans in women under 65 or obesities. And I'm not sure exactly what the American Thoracic Society, they've got 5.
Yes.
Somebody could probably tell me what they are. But what I'm driving at really is, once we're talking about this team management, but it's incumbent, I believe, on the respiratory community and the pulmonologists to identify those parts of the management program which are not necessary. We recognize what's important to do something, but not to inflate the cost so it puts it out of reach. And that, to me, is a very critical component. So we're talking about the cost effectiveness and the value of everything we do so that we're delivering the appropriate care. We recognize that there's $750 billion of costs in the $2.7 trillion health budget. Some of that's due to us and administrative complexity, but a great deal is due to giving the wrong treatment at the wrong time in the wrong place. And if we can correct those things in the rehab world and the pulmonary management world, it'll go a long way to making this.
Yes, thank you. Yeah, there actually is, it's a coordinated effort between the American Thoracic Society, American College of Chest Physicians, with choosing wisely. They had actually 10, they put up to 5. I know there's a manuscript in circulation, only the top 5, and so that it will, it's awaiting comments and should be out shortly. Let's see, I'll just bring this up about plans working to increase the detection of undiagnosed COPD with the use of spirometry. Is there any, what sort of strategies are health plans engaged in?
Yeah, for symptomatic patients, we do want to make the diagnosis, and we have spirometry available in all our chronic disease management centers. We have 16 of them. And we want to make the diagnosis because we don't want to be treating asthma with COPD.
I think that still spirometry is certainly underutilized in the general community.
Let me just tell you, the interesting thing about spirometry, having run the pulmonary lab at Cedar Sinai some years ago, the guy recalls as he was a fellow at the time, and look how well he turned out. And the issue is with these computerized devices, when you take one deep inhalation and blow it out, you get 100 variables, which if you stick a CPT code on each one of them, you can build a whole truckload of dollars. One of the issues is, what do you really need? To me, you need the FEV1, the FVC, and the FEV1C ratio, where you get the mid-flow rates or a flow volume loop or this and that. You know, that looks nice, beautiful diagrams, but build for each of those elements. It's just, to me, superfluous. So I'm just re-emphasizing this point of doing what's appropriate at the right time and not throwing in a whole bunch of other stuff that you can build for, but which doesn't add to the outcome.
Yes, and then spirometry is part of what we're choosing wisely, but I'm not sure exactly what number it is. But it's not. It's directed. It's not to use it in asymptomatic patients, which is actually the U.S. Preventive Task Force recommendation as well.